Great. Thank you. So speaking of thinking wide, we're going to be moving on to our next scale. So thanks again, Andres, Samantha, and Diana for your talks. And I want to emphasize, we're dividing this up into scales, but this doesn't imply or shouldn't imply that you should stick to one scale when thinking about nutrition. But this is a way of sort of dividing up the different areas that people are addressing currently. So we're moving on to, we started with genetics, we moved on to physiology and biology, moved on to the individual, so that the whole person and the behaviors, thoughts, etc. And now we're moving beyond the individual, so above the skin to everything around the individual. And that's what we call the social-ecological scale. So we're going to start off with Kayla De La Haye, who's from the University of Southern California, then move on to Sean Duffy, who's at Amada Health, and then concluding with Michael Howell, who's at Google Health. Now, they're going to be presenting some of the work that's being done. Since we're dealing with a social-ecological scale, some of this may be specific to nutrition and some of it may not, but they are all related to nutrition in different ways. So with that, we're going to have each give a 5-minute presentation and then have a discussion afterwards. So I'm going to hand over the virtual mic right here over to Kayla to get us started.
Thank you, Bruce, and welcome everyone that's attending. So I'll speak briefly about innovations in research on the social and ecological settings in which people access and consume food, and why this is an important aspect of precision nutrition initiatives that focus on healthy eating really from a public health standpoint. I don't have any conflicts to disclose. So many speakers at this workshop have emphasized that eating and nutritional health are part of this complex system influenced by people's genetics, physiology, knowledge and skills, as well as by broader social and ecological factors. And these ecological layers are a complex system because many factors interact across the levels to influence not only what people eat, but also under the skin processes like inflammation. And eating behaviors are especially susceptible to social and environmental influences because they're habitual, meaning that they're very automatic and shaped often unconsciously by the cues that are around us. We've also heard how decades of efforts to encourage healthy eating have rarely had meaningful, sustained effects in whole populations. So even when people can exert personal agency, choice, or effort to change their eating in the short term, we've often failed to create social and environmental structures that are going to support the adoption and maintenance of these healthy habits over the long term. And many populations, particularly people who are low income and communities of color, are unequally exposed to structural influences that do not support healthy eating. So there's a long history of research documenting the close links between what we eat and our social environments. The people that we spend time with and the people we eat with influence what we eat. And they encode social rules and social resources that can enable or constrain our food choices. So eating is very much a social practice. Ignoring this is like ignoring the influence of my mostly vegetarian diet on my husband's vegetable intake, or my husband's German origins on my intake of bread and beer. So there are now growing opportunities to use new sources of social data and network science to understand more precisely how social exposures and social networks influence what we eat. This research is showing that increasingly we eat in diverse settings with diverse eating partners as we eat more food away from home, fewer family meals, and we eat with more varied people in our social networks. Across several studies that I've been involved in, we've measured people's social networks and found that on average, people tend to eat food with about 1/4 of the 20 or so people that are closest to them. They eat with family, friends, and coworkers. But we also find that there is a lot of variability in these eating networks across people and across populations. Longitudinal social network research using network analytic methods has shown that nutritional health and our social networks are very interdependent. This is because people tend to select and form social ties with people who are similar to them in terms of health behaviors and health risks. This occurs because of several processes that are listed here, one of them being homophily, the phenomenon that birds of a feather flock together, reflecting people's preferences to connect with others who are similar to them on many characteristics, like socioeconomic status, and characteristics that are often related to diet and health. In addition to these social selection processes, there's also strong evidence that social networks influence people's health behaviors, including eating behaviors, through many social influence mechanisms like mimicry, normative influence, and by providing social support. As an example, in the social network study that modeled social network dynamics, we found that if adolescents had friends who ate a lot of low nutrient, energy dense junk foods, they were likely to increase their intake of these foods over the course of one school year. And this effect of network influence was significant after controlling for who the teens selected as friends, their own beliefs about junk foods, and their demographics. Overall, this is a critical social feedback loop of social selection and subsequent social exposures that influence diet and health. And through these social processes, people with the greatest nutritional health risks are more likely to find themselves in social networks that also confer health risks. And these social exposures then go on to reinforce and influence nutritional health behaviors and can be barriers to behavior change. Or we can address them as part of network interventions. So given this, measuring and then leveraging or altering social networks should be part of our intervention toolkit to promote healthy eating. Here are two examples of network intervention strategies that I've employed in family-based interventions. The first is segmentation, where at-risk social groups such as family or peer groups are the focus of our intervention. So rather than intervening on individuals, the intervention really engages with the social group to promote collective behavior change and foster positive social influences, norms, and support for healthy eating. A second strategy is alteration, where the intervention explicitly tries to change people's social networks by creating new adjacent healthy network ties through intentional group or buddy activities. Lastly, a second major area of opportunity that I'll just mention briefly is to more precisely study the food environments in which people and these social groups acquire and consume food. So in the past, this research has often looked at what people have access to in their home neighborhoods, around their schools and workplaces, and how these food environments influence what people eat. The results have been mixed, but there's some evidence that more exposure to fast food outlets or food swamps and less access to grocery stores or living in a food desert can be a barrier to healthy eating. And again, these exposures to unhealthy food environments are really concentrated among particular populations. But there's now a lot of opportunities using new data and methods to more precisely track the food environments that people are exposed to. And one brief example of this is a new study we're working on with collaborators at MIT that uses big mobility data, information about geolocation captured by smartphones that allows us to analyze the daily movements of large populations over time. And we're using this data to map food outlets like grocery stores, corner stores, and restaurants that people are close to and actually visit as they move throughout their day. And this data gives us really rich information to understand food environments that people are exposed to and how these influence their food choices. In future, this can inform tailored food environment interventions that might intervene in real time based on food environments that someone's exposed to, helping them make a healthy choice. Or they could inform policy that increases access to healthy food through key food corridors. So in closing, we have a lot of opportunities we can pursue that precision nutrition, to ensure precision nutrition is successfully translated to all populations, especially priority populations. We can draw on these innovations in data and data science, behavioral and social sciences to gain more precise insights into social and built environments in which different people acquire and eat food, and richer knowledge of how diets are differentially influenced by various ecological mechanisms at specific times and in specific settings. We can use these insights to develop and test intervention components that might target individuals as well as their social and environmental factors so that all people have the opportunity to consume healthy diets. And so that precision nutrition is not only effective, but also actionable and equitable. I will end there and pass the baton over.
All right, perfect. So hi everybody. So I'm Sean Duffy. I'm the co-founder and CEO of Omada Health, which I think leads to the first conflict, which is the obvious, which I'm the co-founder and CEO of Omada Health. Really quickly, and keen to share a few insights here. Omada's digital care provider, and the big focus for Omada is in the metabolic space. So pre-diabetes interventions, and now type 2 and hypertension, which of course, lifestyle, food, nutrition, and weight loss are critical components. So, what I was hoping to do today is just share some of the smaller kind of interesting insights as examples of some of the things that I think digital enables to us as the community to really learn on how to intervene and help here. So I wanted to start with one question that we ask at the beginning of the Omada experience. So if you are overweight and have prediabetes or type 2, we shuttle you into a subcomponent of a lifestyle intervention. And as part of that, as we onboard you, we ask you to reflect on, in an open-ended way, what challenges you expect to face to try to change your eating and physical activity habits. So this actually gives the coach and our care team a rich starting point for a dialogue to get to know the person, to build trust, to be there to support and understand their sense of their barriers. And we noticed an interesting insight as part of this that we thought we'd bring to the group here that we're starting to be a little bit more vocal at. And funnily enough, it's actually the difference between present tense and past tense in that response. So just to give you a sense, so present tense, which is our members on the way in using words and phrases like "this is," "I am," it is significantly correlated to less weight loss. So examples of a present tense comment from our members would be, "I lack willpower. I crave easily. I hate to cook. I like very few vegetables. I'm a picky eater." That statement right out of the gate is correlated with less weight loss. Past tense, which is "I have been," "I was," "I used to," is correlated with more weight loss. So when we see participants on the way and say, "I used to eat more than one portion of food," or "I have been," anything past signifies really what we kind of call a growth mindset, congruent with some of the literature in this space. So it was an interesting thought experiment. The teams in investigating growth mindsets in the literature decided to look at past and present tense to see if that was correlated to outcomes, and we saw that it was, which was one I think really interesting insight that we're working to build upon, as we speak, and build upon it through our coaching workforce, which is a pivot to a couple of other insights that might be interesting to the group here. So the Omada experience involves technology. We mail a digital scale that has a cell phone chip in it. We have a content curriculum that brings people through their version of the care plan based on their comorbidities and the goals. And then we have coaches. So you have your primary coach, your specialists, and then if needed, we pull in MDs for people with diabetes. We found a couple of interesting insights there. One is that it's very clear based on our data that technology alone is insufficient for driving outcomes. You really need the people involved. With one experiment, we beta tested and A/B'd simply reminding participants if we've noticed that they've not logged a meal in the period of time when they're supposed to during that part of their care plan, notifying them automatically. We tried that. We also tried having coaches notice that, give feedback directly as the coach, to see if there was a difference in the uplift of engagement in that particular activity, but then secondly, the outcomes. Interestingly, when we had the coaches notice the lack of tracking and give commentary on it, it lifted the behavior of tracking to almost about the same level as the automatic nudges, but it produced more weight loss in a significant way. So that human connection point of someone being there, someone observing your food patterns from afar, someone really thinking through on how they can support you and your goals and your awareness of healthy eating, turned out to be a driver above and beyond any automated nudges. So, we found that to be a really, really interesting insight. And what we're pioneering right now is a number of really microscopic, kind of small, we call them coach plays. Many times these are inspired by, produced by the coaching workforce and the team using their human insight. And the goal is to have this huge inventory of these coach plays that we can match them to a particular data pattern and particular need, be it social determinants on health, eating behaviors, you name it. Here's a couple. These are in the category of food. There's many coach plays in other clinical areas as well. This is one that we've tried recently that worked extremely well. And this was as simple as we help the coaches notice if the member tracks the same breakfast 5 times in a row. We found that to be more meaningful than a coach just responding on one tracking moment, where if there's consistency and there's something that we may suggest relative to improvement of consistency, we found that has a dramatic increase in improving health behavior and eating patterns. So that's kind of one example. Another example that's also kind of at a small level that we just tried and saw an effect. The question was, can we influence something as small as participants eating more beans, if that's aligned with kind of their goals and their preferences and orientation. So, we can use NLP to look at what people are tracking. It's free text input to make it simple on participants. And then we can automatically serve suggestions to the coaches saying, look, the member here has not mentioned beans in 30 days of logging, and use that as a bridge and a jumping point to help support the member in changing diet quality. And we've this is hot off the presses. We've seen that work within 2 weeks. So if a coach notices that, comments on that, something about the coach and the feel that creates of accountability with a participant of, wow, interesting. Someone's actually interested in my eating behaviors. They've noticed that over 30 days, I've not logged beans. That's fascinating. Maybe I'll try that. That loop of people plus technology seems to be very effective in creating further accountability and influencing subtle changes in behavior. So that is my 5 minutes. That's what we've got. We are inspired by the power of data science to combine with human love, support, accountability, the things that we know to be true and important in behavioral interventions. And I'm honored to share our thoughts and some of the results we're seeing.
All right, so I'm hoping that's showing up. I feel a little bit awkward coming to a nutrition symposium and not talking about nutrition, but Bruce asked me to give a few examples of work that our team and others have done that may prompt some discussion and open up some ideas. And so that's what I'm going to do. And I'm going to do 2 things. So first is I'm going to give a few examples of epidemiology at scale. And the second is I'm going to leave some breadcrumbs to data sets that we've been seeing researchers and public health teams using and that you can use too. My most important disclosure is that I work at Google. I'm the Chief Clinical Officer in Google Health. I also have some royalties from books that are not really related to nutrition and sort of a long academic history. So 3 examples of categories of these tools that our teams have been working on and we've seen others work on as well. And the first is about aggregated anonymized search groups. So it turns out that a lot of people come to Google and search for things. And it also turns out that when you see patterns in that they can be interesting. And so here's one example. This is from Google Trends, which if you have never used before, Google has a long history of making these data publicly available, which are aggregated and anonymized. And these are examples of the relative interest in weather and in recipes. And then COVID-19 became the largest information need for our users across the globe. Not surprising, but interesting to see. And so Google Trends is available. It turns out that a lot of people have used Google Trends for research. And the second panel are papers on Google Scholar that have used Google Trends as a method. As COVID evolved, we worked to make 2 additional data sets available. One is about search symptom trends, where these are searches for fever over time in the United States at roughly the county level. And in the past month or so, we've made information available about vaccine search insights. So these are relative interest in searches for safety and side effects related to vaccines. And you can see over time, it'll start in mid-June. You can see a density in Missouri and then spreading throughout the United States. And one of the principles we try to do is whenever we have these data, to make the data easily available for public health and for researchers. So that's one breadcrumb. The second area is understanding distance and how it relates to travel time. So if you go to Google Maps and you search for how long will it take me to get to place X, you can put in driving or walking. That's available as an API. And it turns out that you can use that to understand that distance and travel time, a core way of thinking about the built environment, are related but not the same. And so the figure on top here is a research team that looked at travel time to healthcare facilities if you have a car, and the bottom is if you have walking. And so we've been thinking a lot about the built environment. We announced last month the availability of data that joined vaccine locations, which are available from the US government, and travel time, which is available on our GitHub. And then this is an example from Boston Children's of looking at vaccine deserts. And the final example is about aggregated and anonymized community mobility. This is research from a team that looked, largely at the equivalent of, how many people in a given period of time move from one zip code, go from one zip code to another, or from an F2 cell, and looked at ways to map the built environment at scale. And so you can see Paris has a different city structure than Los Angeles. It turns out that mathematical measure of these two things that your eyes can see closely related to pollutant emissions and then to health outcomes into a set of interesting health-related outcomes. As COVID happened, we worked to make a bunch of these data available for both the public and for public health teams. This is the example for the county that I live in, where we're still 51% below baseline and going to work, but only 10% below going to groceries and pharmacies. And the panel on the right, we've seen really great uptake of this data set by researchers with hundreds of papers in this vein. And so those are the things. I wanted to give a few examples of this epidemiology, and then some pointers to aggregated anonymized data sets. And if you want more information, they're all sort of listed at this link, along with a few other things. Thanks.
Okay, thank you, Michael. Thank you, Sean. Thank you, Kayla. Excellent presentations to get our discussion started. And as Michael alluded to, he was talking about the environment and mapping and all those things, and COVID-19 was an example. But all of these different effects, these sociological effects, do affect nutrition. So wanted to start off with the question that many times when people think of nutrition, they tend to think of the individual within the body, the biology, et cetera. And all of you gave examples of looking beyond, not necessarily always in nutrition, but looking beyond, looking at what's around you, looking at the environment. And one of the challenges is getting people to think about this scale when it refers to nutrition and how it might affect nutrition. What are your thoughts in terms of how can technology really help that and help that understanding?
I could jump in first.
Okay.
I think we just saw like the tip of the iceberg of a suite of growing, exciting data sources that not only allow us to understand individuals' exposures across all of these, different levels of social factors and the built environment, but I think what's really exciting is to be able to do this at a large population scale. So we really are able to see differences in populations and populations that might be high risk, and to see how this plays out over time and the dynamics of that. So often that's something that is a challenge in research studies, or where we might equip a small group of people with a bunch of sensors, and those are research participants who have their own biases. This gives us an observational lens, at least, into these large-scale populations over months or years even, and how the repetitiveness of some of these exposures or unique features that people are exposed to in certain groups, that I think is a really promising complement to some of the stuff we'll see at individual sensor levels.
can jump in from my perspective. So two things that, like, when I just dream big for, where we could help support the research community, that always come to mind. One is, like, it is just so hard to do nutritional research to answer the what. They have to, you have to power these trials to be enormous. They're hard to recruit for. Compliance is tricky because in large part you lean on in-person modalities. And I mean, we've now enrolled 500,000 members at Omada. And at some point, we're not there yet, but ask the research community to be patient, be patient with us. But I just want to so badly be able to do randomized, very quick, enormous trials. It's like, oh, you want to do 10,000 versus 10,000 starting in 3 weeks to test X? Perfect. We'll have people, that are willing to do it, and just run those and just do large scale, completely different trial design to help support answering some of the fundamental research questions in nutrition. So that's kind of big dream number one. I think, like, in a couple of years, ideally, knock on wood, we'll be there. I'd love to launch like a research fellowship, inside Omada to try some of that. So that's kind of one. And then the second, it's just a reflection that, is so congruent with many of the thinkers in the space. You have to map any nutritional approach to behavioral realities on what that person can accommodate in their life, given their circumstances, given their context, given their external environment. And that's where digital can really help. Because for one person, based on what they're going through, the stressors, their belief systems around food, their relationship with food, their family environment, all the inputs you might have a very different approach. You might start very, very modest with someone where it's like, look, let's not even try to boil the ocean here. Like, let's just migrate from, less calories or more calories in the drinks you're drinking to less, like something super small that, they can take on. Whereas another, you might be able to take an entirely different approach. So it's kind of the two things that, just to recap, that I've been dreaming about. One, just large scale randomized trials in nutrition to make research easier for nutritional, the nutritional research community. And then secondly, matching of behaviors, leveraging kind of digital trails to nutritional approaches.
Mm-hmm. Oh, Michael, you're on mute.
That better?
Yep.
Okay, good. Yeah. Someday I will figure out how the mute button works. So I think my answers are less insightful than the other two. So the first is it's really important to recognize that we're not all own islands in ourselves. And so as people are thinking about designing studies, understanding that the influence from outside the person may be much larger than the influence inside the person, I think is really important. The second is, and I'm going to tie together a little bit of the discussion in the session before and this, is there's this temptation to believe that all of these new methods with LSTMs and other kinds of neural networks are just going to fix everything. And I have to tell you, I'm at the epicenter of machine learning now. And the number of times I say, like, oh, let me introduce you to my friend confounding by indication or selection bias, they don't fix this. And so the one caution is the math is really hard, and that I still think there's going to be a lot of methods development, and as we understand how error terms cluster across multi-scale things actually at scale. And so I'm glad that folks are working on things like that. But it's easy to hurt yourself with the math and this stuff.
Thanks, everyone. So we have about 4 minutes left. I wanted to pull some of the questions from the audience. This one specifically to Kayla. To what extent are social networks and communities, which are the focus of these research studies, included in the planning or design of the studies? To what extent are they able to give feedback or participate, if at all?
So I think increasingly with these types of social network focused and ecological focused interventions, we're using community-based participatory approaches. And so we have local community organizations, families, really what I think of as like the key network of people that have insight into these things and who are going to participate in creating like social change and community level change, being a part of the work. And so I think a lot of the work I described was some observational studies documenting these phenomena. And as we transition into incorporating social networks into interventions and thinking about local policy or environmental changes as part and components of these other things that we might be doing with individuals, having that network of stakeholders and participants involved in creating that change and articulating that change, I think is a critical step of those interventions being successful and sustainable.
Thanks, Kayla. And Sean, there's a question specifically for Amada here. What is the cost of Amada? Could underserved populations afford these tools?
So we don't have any self-pay for Amada. So it's all, I mean, what we do is run clinical and economic studies and ideally knock on the payer doors to convince them to cover the Amada solution relative to the value that they see. And thus far, we've been pretty successful doing that. I mean, we have, if you add up the self-insured employer kind of people that have access to Amada and the fully insured, it totals about 17 million Americans. So it's actually just under 1 in 10 commercial insured adults in the US now has Amada in some part as a fully covered benefit, skips deductible, no co-insurance. It's coded as a preventive benefit. So, and that's the goal. That's the goal to keep pressing there. Thus far, we've needed, just for reasons of focus, when you're building a business, you always have to say no more than yes to make sure that you're able to keep the team organized and aligned here. We've stayed focused on the commercial markets versus government markets. There's a whole host of go-to-market complexity involved in the government side. In time, that'll change. That's our belief. That being said, we do have, many folks on the commercial side, that, relative to their, annual income, per year would be, require kind of additional and extra needs, which we're well equipped to deliver. But that's the goal is to have nobody pay for Amada and just have it be as part of ideally everyone's medical policy, so that if you need the intervention, it's at no cost.
Thanks, Sean. So we have about a minute for one more question. So what quick thoughts from each of you. Under what conditions in nutritional applications are Bayesian approaches most useful when dealing with hypotheses derived by machine learning? Any quick initial thoughts?
Michael, you take this one.
I'm afraid to wade into the Bayesian versus frequentist debate, to be honest. In general, I will say when we're looking at time series data, we use a bunch of Bayesian structural approaches, and we've open sourced some of that, some of those approaches, whether the classifier is machine learning or logistic regression or a business process rule. But I'm going to pass it over to Kayla or Sean now.
To save the group.
I am not game to tackle Bayesian versus frequentist in 30 seconds.
I mean, that's why I love Federal like this. I'm like there's many areas of what I do where I just feel so blessed that we have incredible data scientists, biostatisticians, at Amada supporting the analysis. I started the company while in medical school, but in medical school, you don't pop out or even partway through become an expert in stats here. So,
okay. Well, we can't answer all the world's questions in 30 seconds, but thanks for your insights. So just wanted to wrap up our day because we're at the hour. So again, wanted to thank all the speakers, all the panelists for discussion. With each of the sessions, we ran out of time because we always have more material to talk about than time. But thanks for sticking to the time limits and moving things along. We covered some examples of different methodologies, technologies, and approaches for each of the different scales. With the emphasis, we want to emphasize everyone, this is just for organization's sake. These nutrition really crosses all these different scales. In fact, you saw some examples of, offered, for instance, from Sean and Kayla, where you're really looking at different scales, and Samantha and Diana, et cetera, offered some of those examples. So we want to go forward, moving to the next day, keeping in mind that, these complex systems of all different scales affect nutrition. And that's one thing that was pointed out during the first day. So just as a preview to the third day, we're really going to take things another step and say, okay, what are some of the broader issues when it comes to implementing and disseminating these different types of approaches and tools that are available when you're talking about addressing precision nutrition. So we're going to have talks about regulatory issues, communications issues. We're going to, of course, revisit the thought of making sure we maintain equity and not enhance bias and enhance health disparities, and actually do the opposite, trying to address health disparities. So with that, I want to thank everyone who attended and the audience for all the questions. These workshops are meant to really introduce some of these concepts and start the discussion and continue the discussion. So lots to talk about. I will plan on giving a summary of day 2 to start off day 3. And with that, thank you all, and looking forward to the day 3 activities.